we need to talk about an emerging population at heightened winter cardiovascular risk, people recovering from COVID-19. With millions experiencing long COVID, this represents a substantial group requiring specific winter precautions, yet guidance remains frustratingly limited. COVID-19 infection, even mild cases that didn't require hospitalization, can cause lasting cardiovascular damage. Myocarditis, inflammation of heart muscle, occurs more frequently than initially recognized. Pericarditis, inflammation of the heart's lining, can persist for months. Endothelial dysfunction, damage to blood vessel linings, appears common even after apparent recovery. Patients months after COVID show persistently elevated inflammatory markers. The same cytokines and inflammatory signals that peaked during acute infection remain elevated at lower levels for extended periods. This chronic inflammation affects cardiovascular stability and likely increases risk during winter's additional cardiovascular stressors. Autonomic dysfunction is remarkably common in long COVID. The autonomic nervous system regulates blood pressure, heart rate, and vascular tone automatically. When this system is disrupted, people experience inappropriate heart rate increases, blood pressure instability, and exercise intolerance. These symptoms, sometimes called POTS-like syndrome, create baseline cardiovascular instability. Compromised cardiopulmonary reserve means less capacity to handle additional stress. If your cardiovascular system is functioning near its limit during rest or minimal activity, cold weather's additional demands might exceed capacity. Activities you managed easily pre-COVID become genuinely dangerous post-COVID in cold weather. Microclot formation has been documented in long COVID patients. These aren't the large vessel-blocking clots that cause obvious strokes. They're microscopic clots in small vessels throughout the body, including the heart and brain. Winter's hypercoagulability could worsen this microclot burden. The combination of residual cardiac inflammation, autonomic dysfunction, compromised reserve, and baseline hypercoagulability means cold exposure poses amplified risks for post-COVID patients. Yet, specific guidance for this population is largely absent. Most cold weather cardiovascular advice predates COVID-19 and doesn't account for post-viral cardiovascular syndrome. Risk stratification for post-COVID patients should include several factors. Duration, since infection matters, with more recent infections creating higher risk. Severity of acute illness correlates somewhat with long-term cardiovascular effects. Persistent symptoms like chest discomfort, palpitations, or exercise intolerance indicate ongoing cardiovascular involvement. Cardiac MRI can detect inflammation and damage not visible on routine testing. Post-COVID patients with cardiovascular symptoms arguably should have cardiac MRI screening before returning to full activity, especially before their first winter post-infection. Modified activity guidelines for winter months should be more conservative for post-COVID patients. Previous exercise capacity doesn't predict current capacity. A previously athletic person might need to dramatically reduce intensity and duration. Cold weather exercise might need to be postponed entirely in favor of indoor alternatives. Graduated return to activity protocols exist for athletes recovering from myocarditis. Similar protocols should probably apply to post-COVID patients attempting cold weather activities. Progressive increases in duration and intensity over weeks or months, with careful symptom monitoring, might prevent catastrophic events. Vaccination considerations create complex questions. Does vaccination reduce long COVID cardiovascular manifestations? Does it increase risk for those already experiencing cardiac symptoms? Current evidence suggests vaccination is generally safe and beneficial, but individual assessment seems prudent for those with active cardiac symptoms. Medication management for post-COVID cardiovascular symptoms is evolving. Some people benefit from beta blockers for inappropriate heart rate increases. Anti-inflammatory medications might help persistent inflammation. Anticoagulation is controversial but sometimes used. These decisions require specialist input, ideally from cardiologists familiar with post-COVID cardiovascular complications. Monitoring techniques for autonomic dysfunction include simple orthostatic vital signs. Check heart rate and blood pressure lying down, then immediately upon standing, then after 3 minutes standing. Excessive heart rate increases or blood pressure drops indicate autonomic dysfunction requiring activity modification. Connection to rehabilitation resources helps. Post-COVID clinics are emerging in many medical centers. Cardiac rehabilitation programs can be adapted for post-COVID patients. These structured programs provide supervised exercise progression and symptom monitoring. A winter safety plan specifically for post-COVID patients with cardiovascular symptoms should include limiting cold exposure, modifying exercise, maintaining excellent hydration, avoiding temperature extremes, and knowing when symptoms warrant medical attention. Chest discomfort, severe palpitations, or significant new shortness of breath demand immediate evaluation. The broader message is that COVID-19 has created a new population at elevated cardiovascular risk, and winter amplifies that risk. If you've had COVID and experienced any cardiovascular symptoms during or after infection, approach winter with enhanced caution. Your cardiovascular system might not be as resilient as it was pre-COVID. Recognizing this vulnerability and taking appropriate precautions could prevent serious winter cardiovascular events.